So you're going to tell us about a few more things.
Obviously, the other thing to talk about is diet. We're going to speak more about that later. But just again, it's an opportunity to think about the diet again, think about weight. Definitely a BMI of greater than 27. We should be trying to encourage the person with diabetes to lose weight. And the obvious things like smoking, alcohol, and checking rubella and COVID status. It's also an opportunity to make sure the complication screening is up to date. So, for example, when did you last have your eyes screened? When did we last have a kidney function or a microalbumin? The reason I say that is because pre-eclampsia is actually more common in a diabetes pregnancy. So it's really important to have a baseline kidney function and microalbumin so that during the pregnancy, one does not get confused as to what is actually a new finding. And thyroid function is important to check as well.
And Dr. Akinsola, preeclampsia you mentioned. So could you just say a few words about that and how it is related to the diabetes during pregnancy? Because people would have heard of it, but wouldn't necessarily know about it.
Okay, so obviously I'm not an obstetrician, so I can't speak with an obstetrician hat on, but preeclampsia is a very common condition that occurs in pregnancies, both for women with and without diabetes, where the woman who is pregnant produces protein in the urine and high blood pressure. And it can be a medical emergency for the mother and for the baby. The way it's detected is by having regular urine checks. So any woman that's pregnant goes for regular antenatal appointments. One of the things that's done in an antenatal appointment is to have a urine checked. Important to note that for women with diabetes, checking the urine is not for glucose. Most women with diabetes will have glucose in the urine. That is a poor indicator of diabetes control. The reason for checking the urine is actually for the presence of protein, because that is one of the factors that helps determine the diagnosis of preeclampsia, along with a blood pressure that has become elevated. So it's a very important diagnosis to make. It might require medication, and sometimes it requires for decisions to be taken about when to deliver the baby.
Yeah, so as you say, it's a really important condition. Thanks very much for outlining that. And you're going to move on to talk about type 1 diabetes in pregnancy?
Very briefly, I'm not going to spend too much time on type 1 or type 2, just in the interest of time. The only things I want to flag up about type 1 is that NICE have recently recommended that all women with type 1 diabetes who are pregnant should be offered continuous glucose monitoring. This is because we know that this is associated with better outcomes for the baby. And for those women that don't want continuous glucose monitoring, then they could have the Libre sensor, which, as you know, is the sensor that can be worn on the arm, and you can use your mobile phone to scan. The other thing about type 1 diabetes is the risk of diabetic ketoacidosis. So any pregnant woman with type 1 diabetes should be offered a ketone meter. And a real plea to my primary care physicians about making sure that women with diabetes always have sufficient strips for monitoring, because these women have to monitor at least 4 to 6 times per day. Quickly on type 2, the key thing about type 2 diabetes is that by far, other than gestational diabetes, the commonest form of diabetes in pregnancy is now type 2. Most of these women are looked after in primary care. Many of these women are from ethnic minority groups or poor socioeconomic backgrounds, so often their diabetes is not particularly adequately well controlled, and they often have other comorbidities as well. So this is the group of women that are sometimes difficult to find, and sometimes they require a lot of input to get them adequately prepared for pregnancy. So this just highlights the risks to mother and baby. So if a woman with diabetes comes and says, well, actually, I would really love to think about having a baby, but I'm really concerned, they are right to be concerned, because it is not without risks. The risks to the mother are many, including miscarriage if the diabetes control is not adequate right before conception. I've already mentioned pre-eclampsia. It's quite likely that there's a high chance the woman might have a preterm delivery, which means a delivery before 37 weeks. Very high chance that they may require an operative delivery, i.e. caesarean section. And things like hypoglycemia and ketoacidosis are more common. To the baby, we've already mentioned congenital malformations, 2 times the risk of the background population of having a baby with a birth defect if the diabetes is not adequately controlled. Large babies is not good, and we'll see that in a moment, and the reason why babies of women with diabetes are large. Having a large baby is associated with having birth trauma, and also again the need potentially to have caesarean section delivery. So the risks are not small, but what I must emphasize is that good control means good outcomes. So we can mitigate all of these risks by supporting women with diabetes to have good control of their diabetes both before and during their pregnancies.
Yeah, hugely important. Thank you.
So we're going to move now to gestational diabetes, which is actually by far the most common form of diabetes in pregnancy. It is a diabetes that develops in pregnancy and usually goes away after the baby has been born. And you can see that it can affect up to 18% of women who are pregnant, and particularly so in women from certain ethnic minority groups. And we're going to come on to the risk factors in a moment. A really important statistic is that for women with type 2 diabetes, over a third of these women have had a previous history of gestational diabetes. So when you think of the people that have not yet been diagnosed with diabetes, the so-called missing million or thereabouts, a large percentage of these patients will be people that have had gestational diabetes when they were pregnant. And so this is a group of people that we must we must keep an eye on and keep monitoring and keep trying to encourage them to minimise the risks of developing future diabetes.
And I think it's really important that I think now certainly the awareness has been raised, and the awareness has been raised at sort of multiple intersections. So in terms of people who develop gestational diabetes, in terms of secondary care, informing those women that they're going to be at increased risk of developing type 2 diabetes in the future. In terms of primary care, we're much more aware of this, and I think much more vigilant about chasing up ongoing monitoring of those women when they've delivered their baby, to ensure that we can try and reduce the risks of these women developing type 2 diabetes or delay the development of type 2 diabetes in these women. But once again, there will still be people who had gestational diabetes and didn't realise that put them at risk of developing diabetes type 2 in the future. So again, we want to raise awareness of that really important point, and those figures just speak volumes for that increased risk.
The important thing to say about gestational diabetes is generally it doesn't come with any symptoms. It develops later on in pregnancy, and it's not usually associated with any risk of congenital malformations unless in that group of women who actually had pre-existing diabetes which hadn't yet been diagnosed. The reason it develops is because the hormones that a mother has to produce during pregnancy to support the growing baby tend to work against insulin. So these hormones cause what we call insulin resistance. For most women, we're able to produce enough insulin to deal with blood glucose levels, but in those women who are unable to achieve the amount of insulin that's required, they are the women that tend to develop gestational diabetes. So who are these women? Well, NICE kindly recommended that there are some women who are at very high risk of developing diabetes in pregnancy. These risks will not come as any surprise because it's similar to risks for those people that are going to develop type 2 diabetes. So for example, obesity, having a family history of diabetes, Having a previous history of gestational diabetes automatically puts a woman at risk of future gestational diabetes, and coming from an ethnic minority group with high prevalence. So this will include women of Black, African and Caribbean origin, South Asian women and Middle Eastern women are all at very high risk of developing gestational diabetes. And if you've had a previous large baby, i.e. a baby of greater than 10 pounds or 4.5 kilograms. So for all of these group of women, when these women become pregnant, they will be offered screening for gestational diabetes when they are seen by their midwife at their first booking appointment. Screening for gestational diabetes involves a glucose tolerance test. This is a test that involves a woman having to spend some time coming up to the hospital. They have to come fasted, so that means nothing to eat or drink overnight. They have a blood test followed by a glucose load and then a blood test after 2 hours. This test is usually performed between 24 to 28 weeks, and then depending upon the results of that test, gestational diabetes will be diagnosed. What you can see from the criteria is that the factors for diagnosing gestational diabetes are actually quite low blood glucose levels. So you only need to have a glucose level of above 5.6 fasting or 7.8 2 hours post glucose to have a diagnosis of gestational diabetes. During COVID, the COVID pandemic, which changed a lot of practice, the Royal College of Obstetricians came out with new guidance about diagnosing gestational diabetes because of trying to minimise the amount of times women had to physically come to the hospital. So they turned away from using the glucose tolerance test to using either a fasting glucose or an HbA1c. And you can see that if you have an HbA1c greater than 48 at booking, then that's generally type 2 diabetes. If it's between 41 to 47 millimoles per mole with a previous history of gestational diabetes, you will be managed as gestational diabetes. But if those results are normal at booking, you'd go on to 28 weeks to have an HbA1c, and anything greater than 39 millimoles per mole was diagnostic of GDM. So you can see that the actual method of diagnosing gestational diabetes changed during the pandemic, and that had consequences in terms of the number of women being diagnosed. In fact, more women were being diagnosed, which obviously put a lot of pressure on maternity services.
So the diagnostic criteria for gestational diabetes pre-pandemic was different to what it would be for somebody who is not pregnant. And then during the pandemic, it again changed to be really sort of pragmatic, because it was trying to minimize the exposure of women having to come to the hospital unnecessarily, and trying to minimize that. So yeah, it's all about that challenge that pregnancy poses to the body, and that challenge can then sort of produce the things like the insulin resistance in some women who are at risk and then go on to develop gestational diabetes. I used to say to women, pregnancy is a challenge to your body, and it can do many different things. And I suppose one of the things, the way it challenges it with the hormones that are produced, as you mentioned, Dr. Akinsola, is that it can then produce this insulin resistance, raise blood glucose level above what we would consider normal, and then that can cause the gestational diabetes.